Well, hello, and how are you guys doing today? I'm going to actually cover 3 chapters with this one extended PowerPoint, and you're also going to have this in your course content under the PowerPoints, okay? What I did is I'm going to do 22, 23. I also took a very small portion of 28, which is your acute respiratory distress syndrome. You're going to be talking quite a bit about that in 4th semester when we get to mechanical ventilation. It makes a whole lot more sense at that particular point. And then also in 5th semester, when you get to perinatology, you're going to talk about the infant portion of the acute respiratory distress syndrome. So I'm not too concerned about you putting a lot of effort into that chapter right now, because like I said, in 4th semester, you're going to talk quite a bit about it, okay? So the first thing we're going to talk a little bit is about a flail chest. And what you're seeing here is you can see when a person is breathing with a flail chest, they've lost the integrity of the chest wall. We're also going to see this, or actually talk a little bit about this when we talked about pendolift. And pendolift is actually, you're going to see it in the pneumothorax PowerPoint. Well, what happens with the flail chest, when you take a breath in, instead of the chest going out, it actually collapses on itself. And then when you exhale, what happens? Instead of going back in, it now goes out. So it's the opposite of what you would expect. And this is called paradoxical breathing. And we are going to hear more about paradoxical breathing as you go through the different courses, but that's exactly what it is. There is no support for the chest wall. Basically, the definition of this is 3 or more adjacent ribs that are broken in 2 or more places, okay? That's what causes the chest wall to become unstable. That's what causes the problem with the organs underneath it. As you can see, it compresses and restricts the underlying lung. You can cause damage to the underlying lung. You can end up with a pneumothorax if the rib is broken and it actually goes into the lung. And at that point in time, now you have a flail chest and a pneumothorax, okay? Because of what happens to the underlying lung, this is a restrictive lung disorder. So there you can see a little bit, the ribs are very unstable. Your lung volume has to go down. It has to go down because you're not breathing appropriately. There was one time on TV, one of the emergency room shows where this lady was in there and she was screaming. She couldn't breathe. She couldn't breathe. And they're looking at her and then went ahead and got an x-ray and found out she had a double flail. She had it on both sides of her chest. And they're going, I wonder why she can't breathe. Because every time she wanted to breathe, her lungs weren't cooperating. You have atelectasis. You're going to have that pneumothorax with the lung collapse. You can also have a bruise or lung contusion at that particular point. And all of this, because you cannot get rid of the secretions and all the things going along with it, you can now end up with secondary pneumonia on top of it. What causes this? You can have a blunt or crushing injury. Probably the major cause of most of our blunt and crushing injuries below the age of about 65 are motor vehicle accidents. You also can have falls, and we see that with our patients who are 65 and older. That's the main form of injury that we see with them. Blast injuries is another one. Direct compression by a heavy object. Occupation industrial accident. If you have weak bones and you're playing football and somebody falls on you the wrong way, you can also end up with rib fractures. So what do we see with this? Basically what we talked about is atelectasis. Why do we have atelectasis? We have atelectasis from the collapse of the lungs. The lungs cannot expand. If you can't breathe appropriately, you're not going to be able to expand those lungs. And then you're going to end up with some pneumonia. Why am I ending up with pneumonia? Because the secretions are staying in the airway. And one thing you want to think about is whenever you retain secretions, you have the perfect breeding ground for some type of an infection. So what happens? These are the same vital signs you see with restrictive disorder. You're going to still have that increased respiratory rate. You're going to have stimulation of those peripheral chemoreceptors because you're hypoxemic. Why are you hypoxemic? The collapsed airways, okay? Remember that. If you cannot get those airways to function properly, you're not going to be able to get the oxygen from the alveoli into the arterial blood, okay? You're going to have decreased lung compliance for the same reason, and you have an increased ventilatory rate. Whenever your lung compliance goes down, you have to maintain your tidal volume and your minute ventilation. How do you do that? You breathe faster, okay? The other thing is, and you probably have had this happen to you, if you go out and you say you hit yourself with a hammer or something, you don't sit there normally and go, you know, that kind of hurts. It's like, I can't breathe because I'm in so much pain. And this is what's going on with you if you're having a flail chest, especially with an accident or something else that caused it. So the other thing, you're also going to see that increased heart rate. The first sign of hypoxemia, always and forever, tachycardia, 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 okay? And remember, because you're tachycardic, your blood pressure is going to go up. There's the paradoxical movement of the chest wall. Remember, when you take a breath in, go ahead and take a breath in, your chest wall expands, okay? If your chest wall doesn't expand, there's a problem. When you exhale, that chest wall relaxes. Remember, exhalation is always passive. It's passive because the muscles and everything are coming back to that relaxed state. With a flail chest, those muscles aren't there to control this, and now it's going to go out, okay? When you don't have good oxygen exchange, you become cyanotic. So you're going to have both peripheral and central cyanosis. When you listen to people, you're going to have diminished breath sounds. And the reason is you're not moving gas. If you're not moving gas, you're not going to be able to hear breath sounds. So with your restrictive lung pathophysiologic, here's what you see with your lung volumes and capacities with your PFT. And you notice everything is basically either going down with very little normal with your RVTLC or your tidal volume. Remember, with the residual volume tidal volume ratio, if everything is being decreased the same amount or fairly close to the same amount with the RV and the TLC, that ratio is normal, okay? It's just we have to remember that that's what happens when you're dealing with ratios. Your blood gases, are we surprised to CO2 going down? These people are hyperventilating. They're trying to breathe, okay? We're going to see the same thing we see with all the other diseases we've talked about, decreased PaO2. Why decrease PaO2? Because we're not able to exchange gases. And if we have collapsed airways in collapsed areas in the lungs, there is no gas exchange. The oxygen has to go down. And with a severe flail chest, you're going to get the same thing as we see a lot of times with the obstructive diseases. You're going to become acidotic. Acidosis, acute respiratory distress syndrome, they go hand in hand. This is what you're looking at with this blood gas. And this is a chest x-ray. As you can see, it's an x-ray of a 20-year-old woman, severe right-sided flail chest. I'm not quite sure if you can see it. Maybe when you bring it up you can, but you can see with those little arrows pointing to all those little black areas, okay? And that is where the flail chest occurs. So what do we do with this? Well, first of all, we also have to be able to get these patients some oxygen. So one of the things we're going to do is we're going to do some oxygen with them. We're going to give them some pain medications and routine airway clearance. This is coughing and deep breathing. This may also mean that on the other side, the opposite side. And remember, contralateral is the opposite of where the flail exists. You might be doing some chest physiotherapy to get that area also cleaned out. How can we treat this? We can take you to the OR, and the thoracic surgeons can go in. They can wire the flail areas together. We can also put you on mechanical ventilation. When we put you on mechanical ventilation, we're going to use PEEP. You guys probably talked about PEEP when you talked about pulmonary A&P. Remember, we all have about 5 centimeters of water pressure of PEEP in our lungs. That keeps the lung areas from collapsing. We're going to give you that 5 plus probably a little bit more. And so what that's going to do is going to keep those airways open. What does that do for me? It makes it easier for me to breathe. I'm starting at a higher level, much easier for me to breathe. And if you're going to be on a ventilator, about 10 days is usually adequate for those bones to start healing so that we can take you off and you can start breathing well. So there are the respiratory care protocols. Oxygen, we got to get you some oxygen. Remember, we talked about this in Therapeutics 1. If you're hypoxemic, you can die as a result of it. We got to be able to get you some oxygen. We're going to do the lung expansion therapy protocol. We can do our PEP devices. We're going to talk about those. We can do our incentive spirometers. We're going to talk about those. We're going to teach you how to cough and deep breathe. And guess what, guys? If we can, we're going to get you up and start moving. If you can get a patient to start walking, you can get them to start taking deep breaths. If you can get them to start taking deep breaths, oh, so much better for them. And if we need to, if the flail is bad enough, we can also put you on mechanical ventilation. So now we're on to our next PowerPoint. This one's going to deal with the pneumothorax. And pneumothoraxes are kind of interesting phenomenon, shall we say. There's several kinds of them. We're going to talk about those. One thing I want to let you know, I downloaded a couple of videos. There's one on how to treat a pneumothorax. It's a pretty interesting one. There's also one from the New England Journal of Medicine that also talks about putting a chest tube in. And so if you're interested, those are pretty cool to watch. This is sort of an extreme case, in case you're wondering what you're looking at. There's your heart, and there's your lungs, and there's no gas exchange. One of the things that you see with an x-ray of a person who has a pneumothorax, where the pneumothorax is, it's black. It's just air. There are no vascular markings, okay? So you're not going to be able to see any of the vessels or anything else at that particular point. So what we're looking at, and as you can see, we call this free air on occasions. It accumulates in that pleural space. Remember, it's that space between the visceral and parietal pleura. And it's not supposed to have this air in there. It's supposed to have a little bit of fluid, okay? And that keeps it from rubbing together. There's also another there's another video that I put on that talks about pleurodesis, and it shows, it's really kind of cool because they do it through the bronchoscope, and they show you putting the talc down there. They can use doxycycline. There's some other things that they can do, and what it does is it causes the chest wall and the lung to adhere together. Hint, don't get it done if you don't have to. It's extremely painful, okay? So anyways, with this free air, what it does, it enhances the natural tendency of your lung to recoil or collapse. What happens with pneumothoraxes, though, is we collapse the lung area. We collapse the tissue at that particular point. So it, too, is a restrictive lung disorder. So we see the lung collapse, atelectasis. We do see some chest wall expansion, especially in our tension pneumos. So if you're looking at someone, you're not going to see it moving hardly because you get to a point where you can't put any more expansion to it. But you would notice that the two sides of the chest are not equal. One is much more um, large than the other side, okay? And the problem we have with pneumothorax, especially with the tension pneumothorax, is you're going to start compressing the heart, the great vessels. You're going to have decreased cardiac return, a lot of other things that are going on at that point. Now, the one thing when I taught this last time, and I did it this time too, looking at it, I kept looking to see tension pneumo equates with death, and it's not there. However, for the most part, depending on how bad that tension pneumo is, you may not have enough time to do anything to take care of this patient. So you can get gas into the pleural space in three ways. You may have a perforation of the visceral pleura, okay? You can have from the surrounding atmosphere through a perforation of the chest wall and the parietal pleura, okay? Or you can have gas-forming microorganisms in an empyema in the pleural space. We don't see that often, though, so it's kind of an interesting one. So to classify them, we classify them as closed. The gas is staying in the pleural space, not in contact with the atmosphere. It's just in there, okay? An open is that you actually have direct contact with the atmosphere and the gas is moving in and out, in and out. We had a patient one time, he was out in his backyard, he was playing, he was like 10, 11, 12 years old. He jumped over this fence and landed on a cactus. When he landed on the cactus needle went in to his pleural space. It went through the parietal pleura and then the visceral pleura and actually gave him an open pneumothorax. So, in case you're wondering what can cause that, that's a pretty good example. People go, a cactus needle? Yeah, it was a cactus needle. Then your tension pneumo, this is the intrapleural pressure exceeds the intraalveolar or atmospheric pressure. What happens, you can get the gas in, you can't get it out. And because you can't get it out, it continues to build up at that particular point in time, and that increases the pressure. So this is just a little picture that I saw, and I thought, wow, what a really cool way to show this. But there you can see your closed pneumothorax, at this point. Let me get my pen here. You can see the air is all through here and that space, and you can see the lung has collapsed at that point. An open one, which what's happening, the air is going in and out. So every time you take a breath, what's going in is going out, but you still got a little extra pleural pressure here. And so we still see that lung collapse at that point. Now, what they tell you to do sometimes with this is to take like a credit card, put it on the outside where the entranceway is into the between the lungs, at chest wall, and you tape it on three sides. And what that does, when you breathe in, it closes it, but when you exhale, you're able to push the gas out at that particular point in time, okay? With a tension pneumo, what you're looking at over here, here's the gas going in. Because the gas is going in and not coming out, there's your increase in your pleural pressure, and as you can see, here's your collapsed lung. But look what's happening over here. This is your trachea, this is your heart is on this side. If this were on this side, we would see everything go in the opposite direction. But on this point, what we're doing is we're taking and compressing the great vessels and the heart at this, and the esophagus also, whatever happens to be in the way. So this is just a picture. This is a nice little x-ray of a tension pneumo. Remember I told you when you have an x-ray, if you notice there are no pleural markings, that is just air, air, air. And if you're wondering, here's your heart, and you can follow your trachea. Look at that. They gave you a little step ladder to go down with the trachea here. And now your heart is coming over, and here it is. You shouldn't have a heart over here. Most of that heart should be over here at that point. So what causes pneumothorax is, for the most part, penetrating wounds from a knife, a bullet, a cactus needle, You can have an automobile accident, something breaks and gets in there, industrial accident. Doing CPR too vigorously, sometimes you can break a rib, and that rib may go ahead and puncture the lung at that point. Spontaneous pneumos, they occur suddenly. We don't really know sometimes why it happens. We do know that for folks who are like 6 feet and above, we see a lot of spontaneous pneumos with those. What they have talked about, and I haven't heard anything that says no, that's not probably true, is what we think is happening is we're getting so much taller, we're outgrowing our lungs. And so what's happening is we're trying to pull the lung tissue, and as a result of trying to pull that lung tissue, we're actually causing spontaneous pneumos. There was a case There was a case one time where this lady was not feeling very well. You're going to see something on this on the next slide too, or the next couple of slides. She went to her doctor, he examined her, he didn't see anything, he didn't feel anything or hear anything, so she left and went home. And a little while later, she went back a couple of days later, she wasn't feeling any better. He sent her and he went and he got an x-ray and told her, we'll call you with the results. Shortly after that, the x-ray was taken and it was being read, and at that point in time she was out shopping, and they called TPD and told TPD to go find her and bring her in because she had a spontaneous pneumothorax. They needed to take care of it. So these don't happen all at once all the time. You can get them to where they're slowly forming, and that's what happened to this young lady. And then there's other ones that can happen. One of the things when we were doing bronchoscopies, when we finished with the bronch, especially if we took bites, to be able to take pieces to run through pathology and things like that, we had to go get an x-ray before the patient could leave because we wanted to make sure that we didn't cause a pneumo. Sometimes, even though we did the x-rays, we would get the patient back some hours later because he did or she did develop a little spontaneous, iatrogenic pneumothorax, even though it's sort of a spontaneous pneumothorax at that particular point. And the other thing is we have to watch when we're doing mechanical ventilation. If we use too much pressure, we can also cause the same thing to happen. So what are my symptoms? First, if it's going to be spontaneous or the other ones too, quickly, you're going to have a lot of pain, okay? And you're going to be short of breath, and you're going to be coughing, and you're not going to be doing well because your heart's not working that well. You will have some hemoptysis, that it's not going to be life-threatening. You have enough problems with the lungs collapsing. You don't have to worry about that. So what do we see with this? Atelectasis. Atelectasis. If you're going to compress those lungs, you are going to get atelectasis, okay? So what do we see? There's your increased respiratory rate because guess what? You are going to be hypoxemic. You also have that penduloff. The penduloff is interesting because what happens with that is as you exhale, the gas doesn't go out. It goes from the unaffected side to the affected side. And then when you inhale, it goes from the affected side to the unaffected side. So it's really like a pendulum. It's going back and forth in the lung. And if you have something like that happening, you're not going to be able to oxygenate it very well, okay? You're also going to have that decreased lung compliance and increased respiratory rate. You still have that pain and anxiety that you have to deal with, and the fact that you're having difficulty breathing. So also the increased heart rate, blood pressure, cyanosis. Remember with this, hyperresonant percussion notes over the pneumothorax. Now, the board at one time, and they may or may not still have that question, because they don't toss their questions for the most part, they'll tell you if you have a pneumo, what breath sounds will you hear? And sometimes they don't put hyperresonant, but they put resonant, and they expect you to pick the resonant, okay? So be aware that resonant equals air. Diminished or absent breath sounds over the pneumothorax. Like I said, you can see that tracheal shift. You saw that on that one x-ray. It's going to shift away from the pneumothorax. You have displaced heart sounds, especially if you're shifting it from one side to the other. And like I said, you can tell that you have something going on because you have an increase in the size of the chest portion of it that has the pneumothorax. I thought this was kind of a cute little picture. Shows you all that good stuff. There's your hyperresonance and your decreased breath sounds, okay? And basically what you're going to do is you're going to do a needle decompression for some of these pneumothoraxes, normally done in the second intercostal space, midclavicular line. You'll see that if you watch one of the videos, it talks about that. And then you can put the chest tube in after that. Pulmonary function test, if you're lucky to do them, this is what you would see. And arterial blood gases, same thing that we've talked about before. Remember that PaO2 has to go down. Doesn't matter if you're alkalotic, acidotic, whatever. You're not exchanging gas. If you're not exchanging gas, that PaO2 has to go down. And so the chest radiograph, increased translucency on the side of it, the black of it, okay? The lack of vascular markings, okay? Mediastinal shift, you'll see that on the unaffected side. Depressed diaphragms, if it's big enough and you haven't gotten to it at that point. And again, atelectasis. So how do we manage it? The smaller ones, less than about 20%, we let them resolve on their own. Anything over 20%, we're going to go ahead and put in a chest tube after we've done needle aspiration. Now, this is kind of interesting. Your book says the negative pressure doesn't need to exceed negative 12 centimeters of water pressure. And 5 is what they give you, negative 5 is what they give you, that's all you need. When you go to see a chest tube or you read chest tube setups, they're going to tell you that the pressure that we set is a negative 20 centimeters of water pressure. If the pneumothorax is big enough, we may even have to increase that, make it more negative, and you sometimes may see that up to negative 40, negative 60, whatever it takes to get the air out of the pleural space, and so that the lung can re-expand. Now, one of the things we're going to talk about when we talk about pulmonary edema is how can you get pulmonary edema? We have what's called flash pulmonary edema. And what I like to tell the students is that everything when we deal with the lungs and the chest cavity is basically pressure, changes in pressure. And so when you're re-expanding a pneumo, we have to watch what we're doing, because if you re-expand the pneumo too quickly, you're going to change the pressure in the inner thoracic cavity. Once you do that, now you're going to end up with flash pulmonary edema. So you've taken care of the pneumothorax. The problem is now you have all this fluid sitting in the alveoli that we have to get out at that particular point. Okay? So then the question is, you go in to see your patient. How do you know the chest tube is working? How do you know that the lung is getting better? We'll see bubbling in the chest tube, okay? If it's been a couple of days and the bubbling has slowed down or almost has ceased at that particular point, then we know that that is actually getting better, okay? And then we leave it there, and you can see it says about 24 to 48 hours, and then we'll take it off. What you have to do when you take the chest tube out is that you have to make sure that you seal it, and they normally use what's called a petroleum gauze. They have a gauze that has like the petroleum on it, and that goes over that area where the chest tube was, because one thing you don't want to do is start taking more air through that opening of the chest and end up with another pneumo on top of the one you just got rid of. So when you're watching your patients and taking care of them and you see it being pulled and you don't see that going on, you need to mention, hey, we're missing something here, and talk to your nurse about that, okay? So we just watch that. What's interesting with this, though, when you're listening to breath sounds with somebody who has a chest tube, around that area where the chest tube is inserted, you're going to hear wheezing and sometimes crackling and different things like that. You're not hearing it in other parts of the lung necessarily, but you will hear it around the chest tube. And so what else do we have to do? Oxygen, oxygen, oxygen. We're going to teach them how to go ahead, take those deep breaths. We're going to have them do a little coughing for us. We're going to go ahead and maybe do some postural drainage with them on the other side. Have to be careful when we're doing that, though, and have them do some of the other lung expansion therapy we have. And in some cases, we may have to put them on mechanical ventilation to go ahead and make sure that we help them with their breathing and their oxygenation, too. And there's your pleurodesis. Just in case you're wondering, pleurodesis is on your board. So, and they may ask you, what is this? And basically what it is, chemical or medication injected into the chest cavity. And talc is one they use. There you can see tetracycline, doxycycline is another one. Lithiumycin is another one. Bleomycin is also a cancer drug, which is kind of interesting there. But we do use that for that. It's an inflammatory reaction between the lungs and the inner chest cavity, and the lung adheres to that chest cavity. So why do we want to do that? Well, number one, if you're adhering that lung to that chest cavity, you shouldn't have to worry about having another pneumo, because now you're not pulling on it. It's part of whatever's going on. And as I said, it is a painful procedure. You can ask the folks that have had it done, can you tell me just a little bit about it? And they'll be glad to tell you a little bit about it. And on to our last chapter 28. Here's acute respiratory distress syndrome, or ARDS. And like I said, you're going to hear a whole lot more about this in fourth semester because we're going to talk about it in mechanical ventilation. So some of the structural changes that you see with this, interstitial intraalveolar edema and hemorrhaging, we're going to talk about oxygen toxicity. Oxygen toxicity is one of the things that we have when we give you 100% oxygen too long. And what happens with that is we get a lot of inflammatory mediators that come into the lungs. And these include our neutrophils, our macrophages, our cytokines, and things like that. And all of that starts to affect what's happening in the lungs. And we start to get this infection that's happening. And there we see the edema, and you can have some hemorrhaging going on. A lot of consolidation, unfortunately. The hyaline membrane is a membrane that goes around the internal portion of the alveoli. All of this, if you think about it, is starting to increase the AC membrane, okay? Your surfactant is deficient or abnormal because you're ruining the type 2 cells at this particular point, and you will end up with some atelectasis. You are not getting good gas exchange. So one of the causes of ARDS is hypoxemia, okay? And the inability to get oxygen delivered to the alveoli. So some of the common causes, sepsis, we're going to talk about sepsis in emergency care. You can get it from aspiration. Sounds like bronchiectasis, right? Pneumonia is another one. That was another pretty good chapter. Severe trauma. ARDS doesn't necessarily happen right away with trauma. It can happen a little bit later, okay? Depends on what you have and how bad it is. Strange with blood transfusions, drug abuse. People go, drug abuse is not going to cause problems with your lungs. I'm here to tell you drug abuse not only causes ARDS, but it can also cause pulmonary edema. Other things we have, central nervous disease, cardio bypass, pulmonary bypass surgery, DIC, there you see disseminated intravascular coagulation. Unfortunately, this is a very late stage of what happens. What's unfortunate about this is, number one, you lose all of your clotting mechanisms. What happens is your blood starts clotting, and you have all these little micro clots throughout your blood system. And if you try to do an EBG or anything, you don't have anything to stop the bleeding at that point. It's also a very late sign that says things are not going really well. We may end up losing you. Toxins, irritants, immune reactions, and there's oxygen toxicity that we talked a little bit about, and we can see the problems with that at that point. So what do we see? The same thing we see with any other restrictive disorder: increased respiratory rate, heart rate, blood pressure, substernal or intercostal retractions. These guys are really trying to breathe. Cyanosis, dull percussion notes, because remember, you have consolidation, okay? Misplaced bronchial breath sounds. They should be in the higher portions of the alveoli in the bronchus, but now they're in the vesicular, where the vesicular breath sound should be, okay? And crackles, because you've got so much fluid and other consolidation in those airways. Whenever you're breathing, what you're trying to do is pop those airways open so that you can actually get some gas exchange going. And what do we see with this? This is actually an x-ray of a person with COVID-19 pneumonia, and I'm sure he has ARDS sitting there with you too. But now you can see with this, there's increased opacity that's throughout the lungs. This is the ground glass appearance, okay? And where you're seeing those little arrows, those are your ground glass areas at that particular point. And that's one of the hallmark signs of having ARDS.